Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the 116th episode of the Codecast podcast. Today, we are in 2020, and I hope you're ready for the new year, a new year of opportunities to get better, and what the next year has in store for us. So today I wanted the episode to really theme what everyone seems to be doing, and that's getting back to the gym, New Year's resolutions, to eat better, to start a new book, a new task, and just come into the new year and decade with renewed focus and getting into shape for 2020. So how can we do that in our medical practices and billing and coding offices? So we're going to give you a few suggestions that hopefully will give you some inspiration to get started, but also some ideas on where to start the process. And I've noticed that there are some things that have been missed in some offices for the past couple of years that for 2020, you really need to clean up because there's some watchdogs out there that are taking a look at some of your business practices. One of these practices that tends to get a little bit overlooked is your execution of your HIPAA agreement, or what we call the Business Associate Agreement, BAA. And you want to make sure that your business associate agreement or your statuses for anybody you partner with. So let's say you have me come in to do an audit, either on-site or remotely, or to do some training. We'd have to have some kind of a BAA agreement. And actually, I should just say BAA. That would be your business associate agreement, which is HIPAA required for anybody that is a vendor or an outside entity that comes into your practice or is exposed to your patient information. And so there's a couple of things that I want you to decide or determine what your status is with a different vendor so that you understand if you have to get these things signed. And I want to take a look at that. Also this month, I've got a couple of articles out that I just want to give you a heads up about. I have one in the CMA, which is the American Association of Medical Assistants. And it's called Read the Fine Print. And it's about the new E&M services for coding. And I actually have some things up on my blog as well. Also in the January 2020 issue of the AAPC magazine they put out called the Healthcare Business Monthly, I have an article on virtual check-ins on page 48, starting on page 48. So check that out as well. Busy month for me for sure. But first, the Codecast podcast is also brought to you today by the FIA Group, an experienced provider of healthcare cost containment techniques offering services designed to control healthcare costs and protect plan assets. FIAgroup.com. Okay, so let's take a look at this business associate decision tree. Always intriguing, good for sure. So is it protected information, or is the protected health information of the patient being disclosed to a person or entity other than in the capacity as a member of the covered entity's workforce? So if the answer is no, then a BA agreement is not necessary. If it's yes, and then you ask another question, is the PHI, again, protected health information, being disclosed to a healthcare provider for treatment purposes? So primary care, referring physician, contract physicians or specialists, contract nursing staff, contract rehab staff. Again, contract meaning they're under your entity. So if you're a large medical group, so you are, I'm in Laguna Beach, so Laguna Beach Medical Group, let's say, and you have multi-specialty or multi-contracts, and they're under your contract, and the answer is yes to what I just asked, then a BA agreement is not needed. But let's say the PHI, again, protected health information of the patient, is it being disclosed to a healthcare plan for payment purposes or to health plan sponsors with respect to disclosures by a group health plan? If it's no, then you have to ask some more questions. If it's yes, then if it's just for a health plan purposes where you are a contracted provider, again, a BA not needed. And it's interesting because there's a lot of yes and no's in some of this information. And every time you say no, then you have to ask another question. So if it's no to that, then is the PHI, and that's the protected health information. So I'm going to continue to use the acronym. Is it being disclosed to a government agency pursuant to an official investigation? So Medicare, OSHA, FDA, health department, things like that. If that's yes, they do not require a BA agreement, which I'm really surprised about. And so you don't have to have that as well. But if it's no, then you have to look at it again, another question. question, is the PHI being disclosed to another covered HIPAA entity that is part of an organized a healthcare arrangement in which the originating covered entity participates? So are you, again, participating? If it's no, then you have to ask about that entity. Do they create, receive, maintain, or transmit PHI for a function or activity regulated by HIPAA, including claims, processing or administration, utilization review, patient safety activities, billing, benefits management, practice management, and repricing? If it's yes, then a business associate agreement is needed for health information organizations. E-prescribing gateways, you need to have a business associate agreement there. Data transmission vendors, so, routine access to PHI, personal health record vendors, subcontractors that create, receive, maintain, store, or transmit PHI on behalf of the practice office. I would be a subcontractor, so that would mean, I would be one of those people. And then if it's no, then you say, does the other person or entity provide legal, actuarial, accounting, consulting, data aggregation, management, administrative, accreditation, or financial services, where the provision of such services involves disclosure of PHI to myself or, let's say, another entity? If it's yes, then yes, you need a business associate agreement. If it's no, then again, it says it's really what you're going to do with the information. Then it says, will the other person or entity be able to access PHI on a routine basis? And or is there a possibility that the PHI in the person or entity's custody or control could be compromised by storage, vendor, documents, a shredding company, or anything else? You want to know the answer to that, because I do see a lot of practices that will take their paper records, and I still have practices that are transitioning to EMR, believe it or not. They're not there yet. And they'll take them to a shredding company or something like that. And they don't stand and watch them being shredded. You need to watch. You need to make sure they're shredded, because once you leave that place, then they're responsible to do whatever they want with those records. And sometimes it's just not pretty. So know when you need that business associate agreement. Think of certain vendors that you have coming in and out of your office that may overhear or have access to your health information, the patient's health information. And the PHI, it's protected. It is protected information for the patient. And so know who has to have those signatures in place. I know there's a lot of vendors that come in and out of your practice. And for 2020, this is going to be a really big thing to deal with when it comes to making sure that your practice is becoming healthy, that you are getting into shape and updating forms. Have you updated your forms on your intake sheet? Have you trained your staff on the new way of answering the phone? And making sure that they understand what they need to say now. Understanding for deductibles and copays. Remember, we have brand new copays now that are due, and brand new deductibles for 2020. So making sure that you have updated your patients on that as well is going to be really important. I just noticed that sometimes we run into the new year and we kind of run into it blinded a little bit, and we just don't want to do that. So just making sure that everybody's updated, everybody knows that things now start over in 2020, and that you can kind of run with it and make sure that you understand what is needed and what needs to be updated, refreshed, getting into that shape in your practices, in your coding office. Did everybody get their new coding books? Make sure, check. Do they have access to the 2020 CPT and ICD-10 books? I just gave a lecture the other day, and I realize it's the 6th, but I gave a lecture on the 2nd, and people were still bringing their 2019 books, so they're missing the 2020 information. And they're saying, well, they didn't get there yet. And I said, did you order them? They're like, we don't know. You need to know that information. You can't get into shape unless you have the tools to do that, and making sure that you have what you need in front of you for that. So, and it's actually going to be also part of my coding question today. I had somebody contact me from one of my Alaska clients, actually. And they said, Terry, we're a little confused by some of the information we get regarding Medicare coverages and reporting. And now heading into the 2020 year, can you clear up some things for us, because we are really confused and we don't want to be confused going into 2020. She said, I was under the impression that there was only Medicare Part A and Part B out there. Now I'm hearing that there's more than Medicare Part A and B. Can you clear this confusion up for me? Okay, there's a lot of myths when it comes to Medicare, and I just want to basically give you some fluency to understand some of the components so we can clear up this mythology when it comes to Medicare. So first of all, one of the big myths is that Medicare is applicable to only people 65 or older. That's not the case. Although Medicare does cover those who are 65 and older, it also covers certain beneficiaries under the age of 65 with disabilities that qualify and those at any age with end-stage renal disease, so ESRD. To qualify for Medicare, the beneficiary must be a U.S. citizen and lawfully present in the U.S. and must live in the U.S. for 5 straight years. So there is also location qualifiers as well, making sure that that patient is a U.S. citizen. And that is one of the reasons why Medicare typically is so, they're pulled so thin, because they open-ended some of the coverages where it's not just for senior plans 65 and older. And if they would just move that age 1 year, the money they would save would be crazy. And so hopefully at some point that will happen. It's hard because Democrats say no, Republicans say yes, and you've got a political battle that definitely has a hard time being bipartisan. Another myth is Medicare is either Part A or Part B. So here's something I can clear up really quickly. In addition to Part A and Part B Medicare, the Medicare program also includes Part C and Part D. So here's the definition of each one. So Part A is hospital coverage. That would include inpatient hospitals, skilled nursing facilities, hospice, and some home health services for patients who are homebound. What we mean is that is facility coverage. So it covers the stay of where the patient is housed for their medical treatment. Part B, and just let me back up a little bit. You can't have the same, you can't utilize different coverages within the plan. So if you are utilizing your Part A because you're in the hospital inpatient, let's say for a surgery, you can't use Part B services. It doesn't work. You have to use one entity at a time, or I should say one part of the coverage at a time, because you're certified for that as soon as you become inpatient or as soon as you are using that benefit. Part B coverage, which is what we use mostly, that is medical coverage. This includes physician services, outpatient care, durable medical equipment, all of your preventative services, and some additional home services. Now, can you be in the hospital under inpatient hospital and still get Part B for the physician? Yes, you can get that, of course. What I meant by saying that you can't use Part A and Part B, you can't be in an inpatient stay and then still be certified under that and then automatically try to say, I'm going to, leave the hospital, go to the physician's office and see them outpatient because the place of service changed. As long as the place of service is the same, you're fine. Now, Part C and Part D, there are 2 other parts. Part C is also known as Medicare Advantage Plan. You've seen it probably, MA acronym. These basically replace Medicare Parts A and B. A Medicare patient would not have Parts A and B and C. They would have either A, B, or C. So Advantage plans are Medicare-approved private insurance companies that offer all or most of the services and may provide prescription drug coverage and other benefits. And patients choose to enroll in that. They see a lot of commercials and they decide that's where they want to go. Part D is prescription drug coverage. If someone has Part A or traditional Medicare, they will also have Part D plan, or at least a part of it, to help pay for their prescription drug costs. And usually a Part C plan will include prescription drug programs as well. So just a little myth that's out there. And again, this is probably leading to the confusion of my reader who asked the question. Many people are confused about what exactly MA plans refer to. So again, the Medicare Advantage plans. The reality is that the Advantage plans are an alternative to the traditional A and B. They're not a supplement. With a supplemental policy, the patient's covered by Medicare Parts A and B, and then they also have a secondary or supplemental insurance to pay for out-of-pocket for costs that Medicare won't cover or won't allow. And that's when we talk about, their retirement benefits or something like that. In an MA plan, it replaces Parts A and B. And I know that Medicare gets a lot of questions about Advantage plans because the claim does not go to Medicare. It's a replacement plan, and those claims, again, they don't go to the contracted carrier. They go to the Advantage Plan private insurance carrier. And if the patient has any questions on how a claim is processed under their Advantage Plan, they have to go to that company. Now, another myth, and this is the last one I'll really comment on, and this one is really important. Although Medicare patients do have the ability to change their insurance programs, they have to wait till certain times of the year to do that, and it's called the enrollment period. So a Medicare beneficiary can change plans between October 15th and December 7th, and during that time, the patient can keep the same insurance if they want to, but if they're in original Medicare, they can switch to an Advantage Plan or vice versa, or they can switch to a different Medicare Advantage Plan altogether. But coverage is effective the first day of the next calendar month, and it goes by policy premiums and what's been paid. So it's very important, especially in November to February, to make sure you're getting all of the Medicare cards and everything that the patient has in their wallets concerning Medicare, because things can change. And remember, everybody, this is one thing that you want to keep in mind. Also remember that the new cards became effective January 1st, 2020. So you have to use the Medicare beneficiaries identifier, the MBI number, which replaced the Social Security number-based number before when you're accepting claims now after January 1st. Medicare will reject your claim now if you don't use the MBI number. So those are just some important tidbits to try to get you into shape for the year and make sure that you have a heads up. Our coding question was brought to you today by Medical Economics. Smarter business, better patient care. MedicalEconomics.com for the business of medicine, digital magazine, and health IT. Okay, so for today, I have kind of a humorous personal insight this week, but it is about saving money. And for those of you that may do this, or maybe you have adult kids, or you have kids that are just starting to drive, or anything like this, something that maybe you'll hopefully embrace and be like, oh, I didn't know that. So this week is about saving money in the least places you would expect it. So driving with my daughter is always fun. Now, she's a 24-year-old teacher, and she has a lead foot. So when I get in her car, I feel like I need a double seatbelt just to survive the ride. And oh, by the way, there's no brake on the front passenger side. Have you ever tried to do that? Yeah, it's like ducking into a covered building for parking. Which I do, by the way, when you think that the roof is too low, but she just speeds too much. And I wanted to appeal to her sense of spending, since whenever I'm like, slow down, she just looks at me and rolls her eyes. Mom, I'm fine. But when she goes to a stoplight, she brakes hard. And I'm like, you do realize that it takes more gas depending on how much stuff you have in your car and the weight you're stopping. And that's more money. And she's like, wait, what do you mean? And I said, well, if you would just let off the gas pedal just a little before the light, if you know it's red in front of you or yellow, and then coast to the stoplight a little bit, you'll save yourself about a half a tank of gas a month based on how you brake, which a half a tank in California is about $28, and that's about $336 a year. And if you might even save a full tank as bad as you are with it and double that. And she looked at me and she's like, really? And I think a light went on finally. So in the last couple of weeks, she said, I'm doing that. And what's really funny, she came in the house, she goes, I hate it when you're right. She goes, it took me 11 days this time to have to fill my tank again instead of at the end of the week, which is usually 7. And she goes, and I think you were right. I started doing what you said, and I just let off there and kind of coasted to the light, and then, stopped. And she's like, it's saving me gas. She's like, oh my gosh, you're right. I can't tell you how excited I was when you hear from your kids out loud them say, you were right, Mom. That's a good day. So try to appeal to their sense of common sense and their strengths if you can. And my kid is a numbers gal, so she seemed to get that. So hopefully that'll give you some insight when you're talking to your kids about anything. And for those of you that brake hard, hey, it's costing you money. And with gas prices right now, let off a little bit on the pedal. So hopefully everybody's having a good start to your new year. Make it a great day. It's Terry Tuesday and a great week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.